Hi there. This is Bart Walker from McGuireWoods. Thank you for joining us for today's webinar on investments in the cardiology and vascular physician practice management space. We've got a terrific group of speakers today. We're really looking forward to it. We had originally scheduled this for a couple of weeks ago and actually took this time to improve the program. We've actually got a couple of additional speakers, which we're super excited about. So again, this is Bart Walker, McGuireWoods. I'm a partner in a healthcare group, practice primarily, actually entirely in the healthcare space and almost entirely within physician practice and professional healthcare services. My practice concentrates on mergers and acquisitions, joint ventures on behalf of physicians, physician groups, private equity funds, and lenders all in the healthcare space. With me today, we've got Matt Searles from Merritt Healthcare Advisors, Naya Kehayes from ECG Management Consultants, and Jim Melton, who's with the Cardiovascular Health Clinic. I'd like to ask each of them just to say just a few words about themselves by way of introduction, and then we'll just go ahead and jump right into it. Matt, do you want to just say a couple words about you and what your firm does?
Sure. Yeah, absolutely. Thanks, Bart. This is Matt Searles. I'm with Merritt Healthcare Advisors. We are a M&A advisory investment bank focusing on hospitals, physician-owned hospitals, surgery centers, and practices. We operate nationwide.
Great. Thanks, Matt. Naya?
Hi, this is Naya Kehayes. I'm a principal and an ambulatory surgery practice leader with ECG Management Consultants. ECG Management Consultants is a national healthcare consulting firm, and I'm very happy to be here today.
Terrific. Dr. Melton?
Jim Melton from Oklahoma City. I'm a vascular surgeon, practiced in Oklahoma City for about 22 years, and we currently have a ASC OBL hybrid JACO accredited surgery center.
Great, thank you very much. And with that, let's just jump right into the content. One programming note for the audience: you are able to submit questions through the webinar interface. So if you do have questions, please do feel free to submit them. We'll try to answer as many of them as we can live during the webinar today. But if we don't get to them, we will follow up after the webinar. Sometimes questions are just a little too detailed or beyond the scope of what we're trying to cover, and I know we've got a lot of material to get through, so we will circle back with you. But please do feel free to submit questions. We'd be delighted to answer as many of them as we can. Okay, so here's the overview for our topic today. There's really 5 things we're trying to cover. Number 1, why is the cardiology and vascular sector so attractive? And we'll talk about some macro level observations here. Second, reimbursement opportunities and site of service. Naya in particular has great expertise in the reimbursement world, and look forward to hearing your insights on that. Third, a brief discussion of the M&A market, current status and state of the market given the recent COVID pandemic. That certainly changed the dynamic out there in the M&A world. Next, I'll briefly dive into legal structures and key diligence items. So if you are considering a transaction either on the buyer side or the sell side, you'll be aware of some key issues to look at in that process. And then finally, we'll talk about surviving and thriving in a post-COVID world. And again, feel free to submit questions at any time on this. So with that, I'd like to turn it over to Matt for some kind of high-level overview, and I'll from time to time interject some questions. But Matt, if you want to just go ahead and let's go ahead and launch into it.
Sure. Thanks, Bart. So I'll go ahead to jump ahead to one of the demographic slides. We figured we'd start with demographics, just give a sense at 50,000 feet. So generally, demographic trends favor increased demand for healthcare services, and cardiology and vascular surgery is no exception. So there's a lot of stats splattered across this page, but sadly, 46% of the U.S. population is expected to suffer from some type of cardiovascular disease by 2035, 2030. This, of course, is a result of diet and lifestyle choices, which are not improving in the U.S. Obesity, diabetes, COPD all contribute. Lifespan is also getting longer. So we have decreases in mortality over a 5-year period just consistently occurring post disease diagnosis. And so that just means patients simply need more care. And if we go to the next slide, you know, a pretty grim map kind of showing where the concentrations of disease are currently. And this is a CDC map. And, you know, again, I think those demographic trends favor a lot of specialties. And again, this one's no exception. So I did want to ask Dr. Melton, who's on the front lines of, you know, serving these patients, to comment on some of these trends and demand for his services that he's seen over the span of a, you know, long, successful career there. So, Dr. Melton, I'll hand it over to you.
Yeah, obviously these graphics are not what we want to see for our patients, but the reality is the U.S. is not really healthy. You can't even see the outline of our state because it's so red. And so I think that at the end of the day, we've seen diabetes and severe peripheral arterial disease and coronary disease, you know, accelerate tremendously, and with techniques and technology that's been invented, we've really been able to extend lives significantly, as well as save limbs and provide amputation prevention to a large sector of our patient population, including, you know, the Indian population and African American population here in Oklahoma. So we've seen it grow tremendously, and fortunately we're able to supply the care that those patients need in a focused center that's not so intimidating and has such a large cost center associated with it.
Great, thanks. So next slide just talks about, you know, why do cardiology and related vascular practices present such strong opportunity for physicians and potential investors. So just from our perspective in the M&A world, they're a very strong candidate for growth, investment, consolidation for a variety of factors. You know, certainly point one, it's fragmented and very early stage. And there's a growing migration of cardiologists and vascular specialists back into the private space as the private practice model benefits now from the demographics we noted earlier, you know, accelerating migration of cases out of hospitals related to increased technology and cost pressures from patient payers, improved technique and equipment facilitating the movement of these, you know, traditionally high cost hospital-based procedures to ASCs and OBLs. It all allows for a model that is superior clinically and more cost-effective than hospital-based care. It certainly has access to ancillaries as well. You know, and topping that list, of course, are ASCs, OBLs, MRI, PET scans, pharmacies. But there are, you know, litany of others that you might traditionally associate with cardiology, vascular surgery that are listed on this slide, and significant profitability from each. And Dr. Melton, as I go through those ancillaries, did I miss any, or is that a pretty good representation?
That's a very good representation. Obviously, when you're independent and in these ASC, OBL worlds, you take a pretty significant cut on the ancillary services there on the front line. Not the emerging trends with the first part of that slide, but because of the different reimbursement rates in a office setting as opposed to a hospital setting, but you still can do very well with those services, and you can really do your patients a good deed by having that available on site, so it doesn't require so many visits to the doctor back and forth as it would in a big box setting. So I think that as long as you run them correctly and have them, the overhead structure in the correct position, all of those are excellent ways to improve your practice.
Thank you. And that's, you know, a good segue into the next point about alternative payment models. And so, you know, these specialties are extraordinarily well suited to any kind of alternative payment model, bundling, at-risk models. You know, when you can cut costs by 50% with the same or better clinical outcomes, it allows, you know, arbitrage opportunities for all participants, payers and patients and providers. And I know that Dr. Melton, your practice has had some success with bundling. If you could comment on that as well, that'd be great.
Yeah, we had a lot of success when we opened in 2015 of going out to the commercial payers and getting bundled contracts for, like Matt spoke of, same procedures, at least 30 to 40%, up to 50% savings for the payer for the same procedure, and showing better patient satisfaction and outcomes that are, I would say better, but at least equal and better to the hospital systems, just because of the one-on-one nursing and everything that's involved in a smaller facility. We've seen the infection rates are obviously extremely lower, and these all interest the payers, of course, because of the complications that occur with procedures that naturally occur, cost that system significant money. And so I think that with that being said, we tried to create that center where it was a low-cost, high-quality center with high patient satisfaction and technology that equals any hospital in town. So, but we have been very successful with getting those bundled contracts in almost every procedure we do in the surgery center, as well as the office-based lab.
Great, great. You know, we
Matt,
see too. Go ahead, Bart.
I'm sorry, not to interrupt you. I was actually going to follow up on that and just kind of ask you for your thoughts, and also just kind of, it seems, at least anecdotally from our perspective, it seems like this sector is suddenly the flavor of the month, and maybe not so suddenly. Maybe we just haven't been paying attention. But I know you cited a number of factors here. Are these all the reasons that it's so attractive, or is there something else driving this too?
Yeah, I think we've covered a lot of them. You know, we should touch on, you know, increased patient responsibilities, price transparency, a growing familiarity with retail experience that are all contributing factors, right, that help businesses like this be effective. You know, the other thing that I'll mention as well is that, you know, the cardiology and vascular surgery really particularly well suited to this type of environment, to consolidation. There are other roll-up models that have similar positive characteristics. You know, they're fragmented, they have suitability to the retail environment, but not all of them bend the cost curve while accomplishing efficient, you know, consolidation. Cardiovascular can bend the cost curve just like orthopedics can, but there are others like GI or derm where beyond consolidation and the economies of scale benefits, they really don't bend the cost curve as much. And so nothing is certainly against consolidation. Those specialties, we're strong believers in that as well. But the ones that we're talking about today, Bart, we just find particularly well suited for consolidation, smooth fit into alternative payment models, smooth fit into what we see as, you know, the evolving kind of future of healthcare.
Sure, and then I guess the next logical question, I'd be curious, Dr. Melton, on your views on this as well, is sort of what role does the hospital play going forward? Kind of how does their role change and evolve given all the givens, given the shift to outpatient settings, given the shift in demographics, given the preference for alternative payment models? Kind of where do you see them fitting in the future?
You want me to take that, Matt, or?
Yeah, go ahead, Dr. Melton.
So I think that the hospitals will just have to adapt, and especially with we'll get into this COVID situation and post-COVID after in a little while. But I think that at the end of the day, they're going to have to adapt. A lot of hospitals do have an ASC component to them, just focusing on the things that Matt has already mentioned, GI and ophthalmology and those kind of things. But they need to realize that they're sending all these patients home the same day out of a big box and making, very small margins when you look at the overhead structure, and could do a lot better in an ASC setting, partnered with physicians, or in certain areas. I don't know that that's a possibility. So I think that at the end of the day, it would be the ideal situation would be partnering with physicians to create that model and expand their base.
Great. So I'll move on. I think these slides may be slightly out of order, but let's go with it. So Naya, I think these are your slides coming up here, and I'll hand it off to you.
Sure, absolutely. First I'd like to talk about the CMS ASC rule changes that have happened over the last 2 years. They initially started in 2019 and then moved on in 2020. That basically changed the definition of surgery in an ASC that then enabled many cardiovascular, cath lab, and coronary intervention codes to be added to the ASC approved list and now allowed for reimbursement in the ASC setting. So when you look at the number of newly added codes, coupled with many of the implantable device codes, focused on, defibrillators and pacemakers that have been on the ASC list for some time, just looking at a sample size of codes to give you the magnitude of what the implications are, and as was previously discussed, the savings opportunity from HOPD to ASC setting, based upon the 2018 Medicare utilization data. This represented about, a cross-section of these procedures that are now on the ASC approved list. 566,000 Medicare procedures were performed in a hospital outpatient setting in 2018. If you just looked at a small a migration factor of 10 to 30% shift, that represents 3.7 billion, actually, 247 to 740 million in opportunity for ASCs just at that shift out of the HOPD. But that total volume represents 3.7 billion in the hospital outpatient department and 2.5 billion in the ASC. So that shows you just the magnitude of potential savings just in Medicare with a shift. And you can see on this chart that in many situations, and it was noted before and discussed even on the alternative payment methods, and this is what gets both Medicare and commercial payers, excited about ASCs and OBLs, is that the savings is immense. It can be 70 to over 100% in many instances based upon the differences, in the reimbursement. So a couple of the fundamental factors that are really important to understand and why it's attractive to do a hybrid, ASC OBL from the standpoint of reimbursement is that an OBL is reimbursed based upon place of service 11. In this situation, the physician is paid a state of service adjusted non-facility fee, which is effectively a global reimbursement, and it's inclusive of the professional and the technical components. In the OBL setting, there's no separate facility fee billed or paid, but there is this site of service adjusted reimbursement that is greater than just the professional component, which is what the physician is paid when they perform the service in a hospital outpatient department and or an ASC. Now, in the ASC setting, if you're in the ASC bills and gets paid separately for the facility, but the physician is just paid for the professional services, and that site of service adjustment does not apply. Many of the procedures that are not site of service adjusted, meaning there is no additional payment in the OBL. In fact, you can't really do them in the OBL, such as pacemakers. They're also classified as device intensive codes, and the ASC is paid a global reimbursement, which is inclusive of the device. So these procedures, again, are not typically ones that you'll see performed in the OBL, but are certainly opportunities for hybrid ASC OBL due to the reimbursement opportunities there. So there's a lot of opportunity for cardiologists and physicians that are getting into the OBL ASC hybrid from a reimbursement standpoint. Some of the key factors to consider is that there are procedures that are allowed in both the OBL and the ASC setting. And when you look at the reimbursement variances, it's important to understand that there could be some procedures that are more favorable in the OBL setting under the global reimbursement, and there could be others that are more favorable in the ASC when you add the ASC facility component to the physician professional component. That's all going to depend, obviously, on the case volume and the procedures that are being performed by the group. But it's very important to understand that there are definitely differences, and if you're in a hybrid OBL situation, that may impact, how you're doing cases and which site of service you're going to be doing those cases. So it certainly presents, with the addition of these new codes on the ASC list, it certainly presents a considerable amount of opportunity if you're in a hybrid OBL situation to augment existing reimbursement and income for the cardiologist. I think I will flip it back over to Matt.
Yes. So we're going to do a kind of brief M&A market discussion. The first point I wanted to make here was, make no mistake, hospitals are still a significant employer of physicians. That's grown over the last 10 years, whereas actually private practice has declined. However, as it relates to cardiology and vascular services, where inpatient admission is not required, which is a growing minority of cases, that hospital model is not as cost effective, clearly, for the same outcome. And as a result, now we're seeing migration in these specialties back to private practice. And unless the hospital system can find a way to lower their costs, patient payers won't tolerate paying, double for the same service. And that's one question I get quite a bit is, aren't all cardiologists and vascular surgeons employed by hospitals? And the answer, as we look at the next slide, is a lot of them are, but it's moving back in the other direction. And if you look at the genesis for the movement of cardiologists and vascular surgeons back to the hospitals years ago, it was because of what Dr. Melton referenced, where there were significant cuts on the office side. And now, because of these, models that are being employed, the private practice, then becomes much more effective. So we are seeing really strong demand for a lot of these deals. Actually, before I get into other prevailing structures, I do want to ask Dr. Melton a question about recruiting and whether or not that's become easier, whether or not that model that you've proven out to work extraordinarily well has helped you in your recruiting process.
It really has. The ASC OBL hybrid gives you that ability to recruit younger physicians and even established practices into your practice, whereas if it was just office-based only, that wouldn't be possible because the margins just aren't there. So I think that that's been extremely helpful. It's been the calls to me have been exaggerated on steroids since COVID because all the RVU physicians are being cut, 20, 30, 35%, at least in our region. And they had no RVUs to turn in for 8 to 12 weeks. So that's a problem, and that's an issue with that model that, if that hospital-based office visits and ancillary testing money ever goes away, then it's going to be the same as COVID, basically, because you just can't support paying the doctors an RVU level that they're being paid to support their income. So that has really started the physicians thinking that are employed. And to Matt's point, I think that's you'll see even a bigger shift when these statistics are done, 6-12 months from now, as far as the switch from employed to private.
Yeah, it's interesting because I think a lot of times investment bankers are a lagging indicator of that growth. We come in a little later once these are established and moving. So I guess, Naya, you might be a good indication, a leading indicator as well. Have your cardiovascular clients picked up considerably over the last couple of years?
Yeah, I think absolutely. Since there's more opportunity to do the joint, to go on their own and especially to develop a hybrid ASC, we have absolutely seen the changes from employed to independent. And I think that you're going to continue to see that. The other thing that we are seeing is that hospitals are trying to joint venture with the cardiologist because they know that volume is going to leave. But then many of the cardiologists, may be going independent, and doing their OBL and may joint venture in an ASC. But it's been a really interesting movement. I think we'll continue to see that momentum.
Sure. So just quickly, I'll go through some. Just to be fair, of course, to hospitals and to other types of structures, we definitely see managed care purchasers out there. Optum's a good example, and they would say they aren't a managed care company, but they're owned by United Healthcare, so we lump them in that category. There are retailers that are looking to get into the business as well, and they'll be looking to peek into this space, and they come equipped with a lot of money and retail experience, and those are the CVS, Aetna, Walmarts of the world. And then there's the consolidation of already large physician-run practices, well-run, large regional physician practices that will be formidable competitors for this. But as we're talking about the topic today, we're looking at, kind of private investment in these models, and they're typically employed through an MSO model, management service organization, and there are, of course, typically, private equity backed. Again, the major agent for this is the MSO, where some practice income and ancillary income can be rolled up. The goal is to create that integrated care model, create the economies of scale, create the ancillaries to the extent that they aren't already there. But as I mentioned, there are a lot of specialties that are being rolled up, and not all of them have, all the legs of this table in terms of the strong characteristics for, an attractive private equity investment. These do. They have, everything that you would see in a GI or a derm roll-up, plus they bend the cost curve in a way that those specialties cannot. They're significantly reducing that cost, which of course, creates that arbitrage for patients, payers. Everybody really wins. And of course, this is one of the few options to remain independent, of course, that I think is attractive to a lot of doctors as well. I'm not a big believer in the millennial argument that a lot of them don't want to work for private practices. I think that component exists, but we're always going to have those entrepreneurs, and there'll always be enough of them to drive growth in this model. And just very quickly on MSO structure, which I think will be old hat to everybody on this call, you're looking at an MSO in the middle of the arrangement with the groups and the physician groups and ancillaries around it. And within that MSO, you have the ownership of a private investor and the physicians. And so those models can be very flexible. The percentages I have listed here can easily be flipped. But just as a sense of how these are structured, this is the basic general structure. And with that, Bart, I know you have a bunch of slides to go through, so I'm going to hand off to you.
Yeah, thanks. And before we get into that, it's really interesting. And one of the things that Dr. Melton mentioned earlier, I think dovetails nicely. I wanted to ask a couple of questions in follow-up to that. So one of the things was related to recruiting, and that's kind of interesting to me that this pandemic could be creating opportunities for independent practices to pick up physicians, perhaps the ones who are more productivity, compensated based on productivity, are now seeing a slowdown. They're seeing decreases in patient volume and the money going in their pocket. That's an angle that I had not heard before. And so I'd be curious to hear kind of your perspective on that, and then also if you're seeing more independent practices potentially in financial trouble, or do you see hospitals now losing just buckets of money as a result of not being able to fill up their ORs with cardiology patients?
Thanks, Bart. So I was part of a physician-owned heart hospital group that's pretty much dominated the city well, we built it in 2002 and built the second one on the south side of town in 2007, and they're probably up to about 70 cardiologists, and then probably 10 to 15 surgical people over there now. I hired about every one of them, but they're in bad shape. I mean, they had to shut down a lot of stuff, and that's in Oklahoma. So I mean, that wasn't even a state that was hit very hard at all by COVID. So I think that, man, their sister hospital or partner, Mercy Systems out of St. Louis, is extremely hurt. So I think that that's where all these are coming from, and it creates a really good opportunity for the independent hybrid owners, because they come with established practices. When we recruit, we do recruit occasionally with an established practice. But if they're making their RVU money and they're risk averse, then they're less likely to come. And so with this happening now, it's opened the door wide open to very established practices and very good doctors in the hospital systems that are now willing to look at this model with their eyes wide open and actually are begging to get out. So it's really interesting, to say the least, Bart. I agree with you totally.
It's certainly creating market disruption. Seems like it's creating opportunities, and it's definitely putting stress on existing fractures. One of the questions from the audience was whether it's making recruiting easier for you. Seems like in some respects it may, but in other respects maybe not, as people look for a flight towards safety and stability generally.
Yes, I think it's made it much easier, and they kind of saw that we were kind of a release valve in Oklahoma, at least, for the hospital systems to do high-risk coronary heart caths and also coronary interventions while nobody was allowed in the hospital. So we were kind of a release valve that still worked during COVID. So I mean, it even opened their eyes more in that particular instance. So
fascinating. And then Matt, maybe just circling back to you real quickly, just on the M&A market activity front. How do you perceive, at least the deals you're working on, the ones that I know you're very, very active in this space, as well as other physician practice management niches within the healthcare services industry? How do you see the market changing? Have deals been dying? Are you seeing new deals come to market? Are things still on hold? Are deals moving forward? I'd be curious on your perspective there.
Yeah, just deal closings, right? So I will say, as a general rule, if you're in New England, New Jersey, Michigan, or Illinois, it's been really hard to get going again. And everywhere else in the country, which is most of our clients, they're at 75 to 100%. So no real blip. We worried a little bit about some sponsors maybe backing out, but I think most of them saw it as an opportunity, a relatively short-term blip, which I know we all hope that's the case, although can't guarantee. So a short-term impact to the M&A market, but we've never been busier, and we see that continuing.
Yeah, and for what it's worth, as you know, I spend a lot of my time in our practice. We spend a lot of time in healthcare M&A, and from our perspective, we've seen the same thing. If anything, we see a lot of pent-up demand being created, where deals that were under LOI had gone on pause for a period of time, or had proceeded with due haste, but not at breakneck speed. Now that things are starting to pick back up again, those deals are picking back up. We're seeing new deals come to market, and we're also now seeing some distressed deals for the first time, which in my view is much sooner than we expected that to come up. We thought it would take at least 3, 4, 5, 6 months of distressed market activity to really start to see those deals pop up. So interesting. Well, okay, let's segue. I know we've got we have a bunch of audience questions that we ought to get to. I'm happy to buzz through the legal structure slides. Those tend to be interesting, although not as interesting as the stuff that you guys talk about. So perhaps we can take a few questions from the audience real quick and see how many of these that we can cover in a few minutes, and then I'll launch into the legal discussion. So really just for everybody in the group here, Why now? So what's the specific impetus for this sector getting hot? And I know, Matt, you talked about some of this at the beginning of the webinar, and Naya, you pointed to some of the reimbursement changes. Dr. Melton, you pointed to the pandemic accelerating things, if anything. Why now? Is it really just a confluence of those factors, and is there anything else we haven't mentioned yet that would be interesting?
Yeah, I mean, just quickly, I think it's confluence of all the factors we mentioned. I did see one of the questions had to do with bending the cost curve, and you know, when you looked at taking cases that were up to this point, you know, costing literally two to three times what they would cost in the holistically in the office-based environment, that's a tremendous value add. You are, Naya touched on the reimbursement factors that are now leading to profitable outcomes in that environment. You are able to spread care across the continuum of curve. And I think, look, I think the financial world, which I'm in, automatically thinks that, hey, we see all these trends coming. And, you know, we certainly are ahead of all these curves. But the reality is they're not. There's a real herd mentality. And I think that it takes a while sometimes to adopt some, you know, to get rid of some of preconceived notions for, you know, different structural things perhaps to change in the market. And then, you know, an industry like this can sneak up on you as something that's very attractive. And I wouldn't say it snuck up, but I think for all the reasons we went over, it's you know, it's an attractive candidate, and I think people will realize that.
I would add to that that, you know, just fundamentally, in general, services that can be provided in the outpatient setting are obviously more and more attractive, not only to, you know, the payer and Medicare, but also because of the patient out of pocket as well, and the sensitivity and transparency on cost. There's a whole lot more education going on out there, even, you know, with the payers and in informing the consumer of what their out-of-pocket is. And I think you also see, you know, the narrow networks being developed by payers that are directing patients for eligible volume and eligible case types in the outpatient setting to go to that setting. And it's so driven by reducing the total cost of care, of course, you know, for those clinically appropriate procedures that can be done. And I think you're just going to continue to see more momentum. And I think COVID-19 has accelerated the process, as we've already talked about, because there's patients right now that are apprehensive to go to the hospital. And so that's accelerating the momentum, and the payers are being a whole lot more responsive and accelerating their responsiveness, you know, in getting those contracts set up so that things can move to the outpatient setting.
Bart, I might add to that. I claims, and I totally agree. I think that, you know, the system I came from or built, those two hospitals, basically, we would, you know, patients. I'll just give you an example. We had a patient that had very, you know, significant heart disease. EF was 15%, and we're trying to work up to see if it's ischemic or lack of blood flow to the heart as an etiology. And they had an insurance plan that basically was type of catastrophic is all they had. They don't make much money. They're actually from my hometown in Oklahoma, and so they got quoted $10,000 for a left heart cath at this hospital, and this was, you know, 2 weeks ago post-COVID. So, and they wouldn't even do a payment plan; they wanted cash, and so, you know, we did it for $850, and, you know, didn't make any money, but the patient got taken care of, and, you know, covered our costs. So I mean that in itself right there, and, you know, the patient had a significant coronary lesion that we're going to have to address also. So I think that at the end of the day, those opportunities of transparency and what does a heart cath really cost, and how much money do you really need to make, are very important. And I think that those costs are on the hospital side because of the overhead structure, and I understand that. But at the end of the day, that's why the model, you know, that's why I do what I do, is so you can, you know, take care of patients that always be, you know, to Na's point, they're, you know, the deductibles, how much do they have to pay, and it's just a lot less, because 20% of a smaller number is obviously less than a larger number. So I think that those are very important points.
Great. And Naya, maybe one question for you, and Dr. Melton, probably up your alley too. I think you mentioned this earlier, is whether you've seen any specialists, particularly in cardiology or vascular surgery, accessing value-based contracts or risk-based contracts beyond bundled payments.
I can start, and then Dr. Melton, you want to add to it because I know it sounds like you have been participating in those with your group.
Sounds great.
Yes, the payers are absolutely interested in alternative payment models and value-based, and the physicians, who are participating in these contracts, have the opportunity to gain share and have incentives tied in that can potentially be very beneficial, when there are outcomes tied to, migration into the outpatient setting. And it's definitely, got a lot of momentum right now. And, we see, more and more payers that are, putting these types of models and proposals out, to physicians, that can offer that opportunity for savings.
Yeah, we haven't experienced much risk sharing. We try to do that on the front end a little bit with knowing our product cost going forward with all the procedures we do. It's pretty set, and truthfully there's only a set number of to Naha's point, there's only a certain set of CPT codes that are allowed in this space, both OBL and ASC. And we're pretty right on knowing our cost on depending on what we're doing and how many levels we're doing and what device we're using. And we try to be, sole vendors of one particular device. It's obviously a top-of-the-line device, but if you can do it one vendor, and we always do that because there's not 70 doctors fighting about what they want to use. We all just use the same thing, and we use the highest quality stuff here, but I mean, at the end of the day, it's still a better way to do it and a better way to leverage costs. So I think at the end of the day, we try to do that on the front end on our bundling, but I assume that the outcome is the same.
And one related question, then I'll kind of get us back on track on the legal side of things. There was a question about bending the cost curve. I think it was mentioned earlier. And big question for the group, why is this space able to do that? Why is cardiology able to do that more effectively than some of the other specialties that we've seen out there? Is it the movement, purely just from inpatient to outpatient that creates some of those efficiencies? Or are there other things that are unique to this sector that we're not seeing in other specialties?
Yeah, maybe I'll let Naya and Dr. Melton give examples in cardiology, but let's take derm and GI, cases that have always been done and will always be done in office settings. So to the extent that you're consolidating those spaces which need consolidation and can benefit from them, that's great. But you're not bending the cost curve. You're not lowering the cost of that care to patients. Now you take cases that heretofore have been done in hospitals and you're taking them to OBL ASC and they're significantly less expensive. That's a huge value add that doesn't exist in some other specialties. But Naya and Dr. Melton, curious your thoughts.
Yeah, on our side, it's just all about managing your overhead, your FTE cost, and your structural cost, your fixed cost to exactly know what you have, as opposed to a big box where they have no idea. And your product cost is very strong, and it's very comparative to gigantic GPOs, and because you can all come together as a smaller group and decide on one vendor. And so I think that all those things are positive, and you still make plenty of money on the reimbursement numbers that are given at a much lower overhead cost. And that's really, to Matt's point, the difference is you're moving procedures out of a hospital to this site of service, as opposed to a service that's always been done in the office. So it's a good point.
Yeah, I would just echo that. The savings is significant. It's quite easy to demonstrate the savings. And when you look at commercial payers that are, in many situations, they have significant managed Medicare populations as well. And so, with those managed Medicare populations, they're sensitive to both. And that savings is huge. It can be over 100%. And like Dr. Melton said, when you're in that environment and the physicians know their costs, they're aligning, they are sensitive to, being consistent with their, supplies and implants and so forth, it makes a huge difference on their ability to attain efficiency and to operate under a lower reimbursement scheme that represents a material savings, to the payer, the patient, while providing an opportunity for the physicians.
Great. Well, thank you very much. Let me just spend a couple minutes on the legal stuff in terms of structure and how these things are put together. Matt, I think your slide is a nice segue of sort of the MSO transaction structure and how this all fits together economically. I'll spend just a minute on some of the basics. I think this should not be new to most people, but I think it's always good to have just a brief refresher, and especially for those who are new to healthcare services, it'd be good to just give them a little bit of a primer so we're starting on equal footing. So one of the reasons for this structure is corporate practice of medicine restrictions. In a lot of states, investors and non-physicians cannot own a medical practice directly. And so that results in what you call the MSO PC structure. Here's a helpful visual. This is what the legal structure looks like. I think Matt's slide was a good pictorial of what the business relationship is and how the economics work. This is more of a technical legal diagram in the sense that it shows the PC being the practice entity, the MSO being the management services organization, and the economic link between them as the management services agreement. This is as close to ownership as you can get in a lot of corporate practice in medicine states, and the division is generally between all clinical things, clinical decision-making, clinical activities, patient care. All of that happens in the practice or the PC. And in the MSO, that entity handles all of the business functions, so all the back office support, all of the HR, payroll, financial services, budgeting, planning, AP, AR, billing, collections, etc. Happens in the MSO. So don't want to spend a ton of time on it, but that's the basic structure we're talking about when we talk about MSO PC. If you're not familiar, contrast that with the ASC world, where in most states, anyway, anybody can own in a surgery center. You don't have to be a physician. So you do see a lot of private investors, private equity funds, management companies helping to develop and run surgery centers. So that's one key difference between those two business models. And it's interesting to see the interplay between those two, because a lot of times, at least nowadays, there's a practice component to these transactions as well as an ASC component. And then when you mix in the OBL aspect of it, it adds some complexity on the ASC side. It's sort of a hybrid between a practice and an ASC. So there's nuances there that I think are probably too down the weeds for purposes of the time we have today. But suffice it to say, it presents some interesting and sometimes challenging issues. Okay, next slide. And Matt, would love to hear your perspective on this as well. I think everybody is always asking about valuations and where these shake out, especially in private equity-backed deals. Usually, we see historic valuations at 6 to 8 times EBITDA. That's a little bit misleading, or a little bit slippery, I should say, in that most physician practices don't have EBITDA in the traditional sense, because so much of it is at the end of the year bonused out or paid out as compensation or distributions to the physicians who are owners in the practice. And so it's a little bit difficult to just apply a straight multiple. You do have to bake back into pro forma EBITDA and actually understand how much of their historical cash flow is going to be maintained going forward versus the changes that are made as part of a transaction to the physician compensation scheme overall. So don't want that to be too misleading, but we are seeing relatively high valuations given the COVID pandemic. Unclear how that's going to affect valuations. I do think it is creating disruption in the sense that sellers still generally believe that their business will come back and they'll be right back where they were, whether that's 3 months from now, 6 months from now, or 12 months from now. I think buyers are somewhat taking a wait-and-see approach, and it'll be really interesting to see how many buyers, especially the ones that are involved in competitive bid processes, how much credit they give for past EBITDA or historical EBITDA, given the events the last couple of months. But Matt, curious if you've got any observations on that front.
Yeah, I mean, two things. The original concern, I think, for a lot of folks was just supply and demand. Will the demand for these deals abate? And I think the answer to that is no, we have not seen that. The second point about getting back to baseline, we've been told by multiple purchasers that they want to see 85 to 100% of the baseline to get pending deals closed, and by that I mean deals that are supposed to close pretty soon. A number of these facilities having no trouble getting there. So unless there's a second wave, or you mentioned seeing distressed deals, I mean, to the extent that some of these funds are leveraged, or the balance sheet wasn't as strong, maybe we see some fall off. But at the moment, we're seeing demand. The deals, we're seeing multiples that are satisfactory for us and our clients. I know that the multiple game, if you ask an investment banker, it's 10 to 12. If you ask a buyer, it's 6 to 8. So we'll stay away from the number. But from our perspective, we're still pretty satisfied with what we're seeing, and honestly expect that to continue with a lag, of course, in the totalitarian states of New England and Illinois, Michigan.
Got it. No comment. but good point. Let me try to cherry pick the most useful slides remaining, because I don't think we're going to be able to get to everything we had planned. Maybe this would be helpful just to orient people who are new to the transaction world, just what a typical transaction process looks like. Generally, you're looking at 3 to 6 months. This is what it looks like. That's about all I'll say on the slide. We will send this around, all the slides, to all the attendees. So don't worry if we skipped some things, or if you've got questions after you see them, feel free to follow up with us on those. So finally, let's just spend a little bit of time. I know we've only got a few minutes left on surviving and thriving in a post-COVID world. And I'll just go ahead and open this up to the panelists and just ask each of you, what's the best piece of advice that you have for cardiologists, cardiology groups, vascular surgeons on how to thrive in this sort of post-COVID world we're now living in?
Yeah, Dr. Melton, Naya, you want to start with that?
Sure. Well, I'm fortunate and blessed enough to have a facility. So I mean, we just, in Oklahoma anyway, we're able to turn everything back on a patient visit standpoint, and office visits with continued precautions with distancing and checking patients at the door. But at the same time, I think that none of these patients want to go to the hospital, no matter what they have wrong with them right now. And it's just very, very good to have a facility to take them to and take care of them. I don't think that's going away anytime soon. So I think that, again, I think you're going to see a big transition of RVU physicians to the independent world, and I would welcome it and encourage it. I'm one of those guys, so I think that's what I see happening, and it's an excellent way to survive. Money's very cheap right now, so it's a good time to go and borrow and invest in your future. So that would be my recommendations.
Great, nice.
Yeah, I would echo that. We have literally, God, I think I was just on a phone call earlier today, and literally I'm on several phone calls a week with cardiologists right now that are looking at the opportunity of building and doing an independent OBL. There is, and it is being very much so driven by the fact that the patients do not want to go to the hospital. And, this presents with an opportunity. And the hospitals are worried, obviously, because many of those physicians and those cardiologists are working at the hospital, and they're looking at, what the financial implications are of that, which then, of course, present that opportunity. And it's going to, as Dr. Melton said, continue for some time. So anyway, I will end there, and because I think we're on the hour, and if Matt wants to add any comments.
Yeah, just quickly, without reiterating everything we said, there are serious macroeconomic factors that favor this model, and we went through them. But, we are not going into a depression. We're going to come out of this. The economy's going to survive, and we may have a recession of some type, but everything will come back. So we're not overly concerned, and we think all the factors that were causing consolidation before COVID are going to be put into warp speed now. We will have culled out some of the weaker players, and just financially. And while this was impactful, I think that we don't really see it having lasting impact unless there's something coming that none of us can predict.
Great. Well, thank you all for your time. This has been really enjoyable for me, really interesting. I feel like I learn something new every time we do one of these, and especially with the three of you. So appreciate your time. I know we didn't get all the questions, but we'll absolutely follow up with those after the fact. Contact information is here for anybody who has follow-up questions. We'd be happy to speak with you, and thanks again to everybody for joining today. Have a good day.
Thank you.
Thank you.
Thank you.